Welcome. In this lecture, we'll be discussing dilated cardiomyopathy. Let's briefly discuss an overview of this topic. DCM is the number one cause of heart failure and makes up roughly 90% of all causes. This is also better defined as a systolic dysfunction. The issue is with contraction of getting blood out of the heart. If you remember, there are two primary steps in the cardiac cycle. Diastole occurs when the ventricles fill with blood, and systole occurs when the ventricles push blood out. If we have a systolic dysfunction, we are having a tough time pushing that blood out of the heart. Thus, this is also referred to something known as HFrEF, or heart failure with reduced ejection fraction. Now, why do we get this reduced ejection fraction? Well, let's first go over a brief pathology of DCM. So DCM is due to something known as eccentric hypertrophy, or more specifically, the sarcomeres, which are primary components of cardiac cycle, are added in series. Now, what exactly does that mean, sarcomeres being added in series? Well, it's important to understand that the cardiac system is more like an electrical system, or an electrical circuit. Now, if you remember back to your undergrad days in physics, you learned two primary circuits, series circuit and parallel circuit. So DCM is caused by a series circuit deficiency or pathology. This is an image of what a series circuit looks like. As we can see, these resistors, aka sarcomeres, are being added in series or right next to each other. This leads to two things: elongation, in our case, of the left ventricle, and thinning of that left ventricle as well. I've always remembered this by the term eccentric hypertrophy. Reminds me that E for elongation. That is what's going on when these sarcomeres are added in series. Now let's take a better look at how this occurs. So we see here on the left, we have a normal heart. This area in red demonstrates the left ventricle. This area in blue demonstrates the right ventricle. Compared to dilated cardiomyopathy, these sarcomeres are being added in series. This results in two things, correct? Elongation and thinning. We can see that in this diagram here. We can see that the left ventricle in particular is longer, wider, or elongated, whichever term you want to use. And we can also see that this muscle tissue here, this myocyte, is going to be decreased, right? Which leads to thinning of the left ventricle. This thinning leads to decreased ability of contraction. So dilated cardiomyopathy is associated with decreased contraction. This decreased contraction leads to a decrease in ejection fraction. Hence the term HFrEF, or heart failure with reduced ejection fraction. If I do not have enough muscle in order to contract, that blood is not going to go anywhere. As that blood sits in the heart, and because of the fact that my left ventricle is now wider, I also get an increase in something known as end diastolic volume. Remember the two parts of the cardiac cycle. Diastole occurs when the ventricles fill. Because my ventricle is enlarged, wider, and can hold more fluid, I'm going to have an increase at the end of diastole, the end of filling volume. These three things are very, very important to know for test day, as they like to test you on the pathophysiology via understanding the pathology first. Now, let's go and talk about who gets dilated cardiomyopathy. Without a doubt, the number one cause is going to be ischemia. This is always going to be the number one cause of dilated cardiomyopathy. There are other causes associated with DCM as well, and we'll go over a few of them. Now, I'm also going to highlight differences in how they might test this on your board exams. So let's go over alcohol and cocaine. Both of these can cause dilated cardiomyopathy. Alcohol, aka, is from thiamine deficiency, aka wet berry, but alcohol can also lead to apoptosis of your cardiac myocytes, leading to thinning of that left ventricle, and in turn dilated cardiomyopathy. Cocaine puts a lot of strain on the heart and can also lead to dilated cardiomyopathy. It's important to understand these two because for both of these medications, these are typically reversible and the treatment is going to be different. Typically, the treatment is going to be to stop these illicit substances. Now, another high-yield topic is going to be chemo medications. There's two big high-yield chemo medications you want to know. Doxorubicin, which is associated with a multitude of different treatment modalities, and then trastuzumab. This is a monoclonal antibody, hence the mAb, that is typically used in the treatment of breast cancer, more so HER2. Now, what is the difference between these two? Doxorubicin typically is going to be symptomatic, where trastuzumab is typically hidden or asymptomatic. Hence why when these patients are on this medication, we typically get baseline echoes and echoes throughout their treatment cycle. What you need to know is that doxorubicin leads to something known as myocardial necrosis, destruction of those cardiac myocytes, and this is usually not reversible. On the other hand, trastuzumab leads to something known as myocardial stunning. Myocardial stunning is exactly what it sounds like. It stops the cells from dividing, thus in turn leading to thinning. This does not lead to cell death, thus this is typically going to be a reversible cause. It is also important to note that doxorubicin is dose dependent, D for D, where trastuzumab is not dose dependent. What does that mean? Doxorubicin typically only causes dilated cardiomyopathy at high or toxic doses. Trastuzumab can cause dilated cardiomyopathy at any dose. Understanding these differences is very high yield, as they will sometimes want to know what you may see on, let's say, cardiac biopsy in a patient on test day. So understanding that doxorubicin is associated with necrosis and is not reversible, trastuzumab is associated with myocardial stunning and is reversible. Hemochromatosis is another common cause of dilated cardiomyopathy, although this can also be a cause of restrictive cardiomyopathy. Pregnancy, such as peripartum cardiomyopathy, which can be diagnosed between 36 weeks pregnant up to 5 months postpartum. We will talk about this at the end of this lecture. And then, of course, viral is a very common cause of viral myocarditis. Some common causes are Coxsackie, CMV, HIV, etc. Now, the reason why I'm highlighting the ones in red is because these are typically higher yield and are tested on test day. Notice how alcohol and cocaine have a different treatment modality. Doxorubicin and trastuzumab can be easily compared to one another. And then, of course, peripartum cardiomyopathy we'll talk about at the end. This is also important to know when we talk about diagnosis, as we can use the fundamental knowledge that ischemia is the number one cause to define or to see on imaging modality for diagnosis if that is occurring. And we'll talk about this in a few slides. So now let's get into what symptoms we can see in dilated cardiomyopathy. The symptoms is dependent on if you have left or right heart failure. Now please note that left side heart failure is the most common. And then of course, for right side heart failure, the most common cause is going to be left side heart failure. So typically if you have right side heart failure, you most likely have left side heart failure as well. Now the symptoms are going to be dependent on if you have left or right. For individuals with left side heart failure, this causes blood to back up into the lungs, leading to symptoms like shortness of breath, orthopnea, PND, paroxysmal nocturnal dyspnea, crackles, fatigue. In contrast, right side heart failure leads to systemic venous congestion, swelling of the veins that are draining into the heart. This presents with peripheral edema, JVD, hepatomegaly, ascites, weight gain, etc. So let's quickly talk about what exactly JVD is, because sometimes this is tested or sometimes this information is provided, but not a lot of individuals know what to do with it. It's important to know that the normal JVD is roughly around 8 millimeters of mercury, and that's how it is described. So how do we get this 8 millimeters of mercury? Typically what we do is we take our patient and we lay them at around a 30 to 45 degree angle. Now, what I do is you measure from the sternal angle, that little notch that's right below your thyroid. You can see it on yourself. And you take a ruler and you measure straight up to where you see the JVP, or the jugular venous pulse. When they're laying like this, you should actually be able to see their neck veins pulsating. So you take the ruler and you measure up from the sternal angle there. Whatever that centimeter is, let's say you get 5. You add 5 onto that. The reason why we add 5 onto our value, and we always add 5, is that this is roughly the distance from the right atrium to the sternal angle, okay? So we can see from the base, or I should say the apex of the heart, okay, this this atrium, this right atrium down here, all the way up to this JVP, okay, we can see the total displacement of fluid. Or basically it tells us how backed up is the fluid that's supposed to be in the heart. Again, the normal is 8. So if you ever are given a question stem where they will sometimes give you the JVP or the JVD is measured to be 10, just note that that is elevated, and that is what that is trying to relay to you. So what exactly are the big takeaway points from symptom-wise? Now, there are a multitude of symptoms. As we can see, a lot of people present with JVD. You can get this in constricted pericarditis as well as other things. A lot of people present with lower extremity swelling. This can be caused from malignancies, so just a typical finding for drainage issues. Sometimes standing too long can cause lower extremity swelling. So these aren't really always associated with dilated cardiomyopathy. So the most specific findings that you want to look for in test day is going to be an S3 heart sound, which has a 98% specificity. Remember, an S3 sound is caused by rapid filling of a volume overloaded ventricle. This typically occurs during early diastole, during filling. This occurs just after S2. So here's S2, here's S3. And is produced when blood flows quickly into a compliant or dilated ventricle. Please note that this can be pathologic and is typically seen in heart failure and dilated cardiomyopathy, but it can sometimes also be physiologic and can be in benign finding in pregnant individuals. Sometimes athletes can get an S3 noise, and of course young children as well. But if you see it on test day in a patient that does not seem to be asymptomatic, they are pretty much telling you that this is dilated cardiomyopathy or volume overloaded heart failure, aka acute decompensated heart failure. Orthopnea, on the other hand, has an 89% specificity. Orthopnea occurs when you lay flat, you quickly become short of breath. This typically occurs or sometimes can occur at night, but anytime you lay flat. The reason being is because the fluid in your left side heart goes into your lungs, and when you lay flat, it covers your lungs, which leads to a decreased ability to transfer oxygen, and you get this short of breath feeling. Look for these two findings or these two things on test day. They will typically tell you this in a question stem. If you see this, the first thing you should think of is either dilated cardiomyopathy or acute heart failure exacerbation. Now let's talk about how we define or how we break down dilated cardiomyopathy. The best test for cardiac system is either going to be an ECG if it's an electrical issue, such as an arrhythmia, or echocardiogram if it's a structural issue, such as cardiomyopathy. This is the best initial test and can help look for pathology. Note that this is not the best overall test, but this is the best test to start out with. The reason being is it helps tell us if we have an ischemic cause or a non-ischemic cause. Remember, the most common cause of DCM is going to be ischemia, but there are other non-ischemic causes, such as myocarditis, hemochromatosis, pregnancy, etc. So how exactly does this take place? So here's an image of a heart. Now, let's pretend, for example, that we have that these blue structures are actually arteries. If we have damage to just this artery in particular, what's going to happen? There will not be any oxygen delivery, and thus no energy will be able to be produced in this area. This will lead to just that area of the heart not being able to contract. The rest of the heart, on the other hand, will contract just normally or just fine. Where with viral myocarditis, for example, that's going to lead to an inflammation and damage to the entire heart, which means that the entire heart is not going to be able to contract. So how am I going to know the difference of this on test day? Well, look for these key words. For ischemia, you see something known as focal hypokinesia. One area or a focus is going to be affected. Hypokinesia means decreased. You can also see akinesia, which means without contraction. So look for focal, and then of course for non-ischemic causes like viral myocarditis, such as peripartum pregnancy, etc., look for words like global. It's affecting the entire heart. Thus the entire heart, the left ventricle, the right atria, the left atria, is going to have decreased ejection or decreased contractility. Remember, echo is going to show a decrease in ejection fraction as well, typically less than 55%. So how do we treat people with dilated cardiomyopathy? Well, we use something known as GDMT, or guideline-directed medical therapy. This is approved for HFrEF. For test day, it is utilized for HFrEF, heart failure with reduced ejection fraction, aka dilated cardiomyopathy. This typically follows a stepwise procedure. There are 5 drugs that you should know. The first 3, and the first 3 that we typically start with, are going to be your ACEs or your ARBs. Typically, we do not give these together as they increase the risk for angioedema and side effects. These can be lisinopril, losartan, etc. Beta blockers, the only 2 beta blockers that are typically used in America are going to be metoprolol and carvedilol. And then, of course, spironolactone as well. These 3, for a very, very long time, have been known to decrease mortality and improve outcomes in people with dilated cardiomyopathy. There are now 2 medications that also suggest this. One of these are going to be known as an ARNI, these angiotensin receptor inhibitors. Now, this is known as sacubitril and valsartan. This is how it is going to be shown to you on test day, as they do not typically use brand names. This is also known as Entresto, more commonly in layman terms. Another medication that's going to be GDMT approved is going to be your SGLT2 inhibitors, such as Jardiance or empagliflozin. A lot of these end with FLOZIN, flozin. SGLT2 inhibitors were first only used for type 2 diabetes, but now they've been cleared and they've shown benefit and decreased mortality risk in individuals with HFrEF or dilated cardiomyopathy. Notice how I put these in order. This is typically the order in which they are added on. We typically start with these 3 medications, then we typically move on to an ARNI, and then we typically move on to an SGLT2. We will talk about acute treatment at the end, but first I want to go over a quick practice question. So pause the video, take time to answer this. The answer to this question is going to be E. Now, this is a very important and high-yield topic to know on test day. The reason being is, if you remember to the last slide, these are placed in this order because these are the orders that they are added on, right? So we typically go ACEs, ARBs with beta blockers and spironolactone, then we add on ARNIs, and then we add on SGLT2 inhibitors. We typically add this slowly to decrease the risk of adverse events, but in the case of this, Entresto, or C, on the other hand, cannot be added to an ACE inhibitor, like lisinopril. We see that this individual is on lisinopril. These 2 drugs must not be used together due to the increased risk not only of angioedema, but other adverse effects. They must also usually have a washout period. That's why E is the best answer. They want to know that these medications cannot go together. The only way that C would be the right answer is if C said we switch out lisinopril and we put them on Jardiance instead. This is something that is very, very, very important to know for test day, as they like to make sure to know that you never give an ACE with an ARB. Now let's keep moving forward with other treatment options, such as operative treatment options. Now there are 2 primary operative treatments for dilated cardiomyopathy. Both occur with a set ejection fraction. That set ejection fraction is typically less than 35%. So the first one is something known as an AICD. Essentially, this is a defibrillator. This is done when the ejection fraction is less than 35%. This can be done with GDMT. So just because a person has AICD does not mean that we do not treat them with GDMT. The AICD is to prevent arrhythmias. Because of this low ejection fraction, you're going to have built-up stress in the heart as the fluid likes to sit there. This puts a lot of stress on the system and can lead to arrhythmias. Thus, we typically add an AICD. The other option choice is going to be something known as a biventricular pacemaker. This is also going to be done when the ejection fraction is less than 35%, but you also need to have a QRS greater than 120. This should make sense. The QRS greater than 120 is going to be a widened QRS. Widened QRS implies that there is some sort of ventricular desynchronization. The ventricles are not aligned properly. They are not contracting appropriately. So we need to sync them up again. How do we sync this up? We always add into a pacemaker. Pacemaker synchronizes cardiac cycle. We do that biventricularly. Understand and know this. Both of these times, we still continue with GDMT, and both of these are going to be given when the ejection fraction is less than 35%. That's why they are in the same color. Just know that biventricular pacemaker is added on when the QRS is greater than 120. Definitely know this slide for test day. Now let's talk about a caveat to dilated cardiomyopathy, something known as peripartum cardiomyopathy. This is a very rare occurrence, typically only occurring in 0.04 to 0.1% of births, and results in left ventricular failure. This is typically idiopathic, but is thought to be caused due to some sort of volume overload or increased volume circulating throughout the body during pregnancy. The definition is important to know, as this can occur greater than 36 weeks while pregnant, all the way up to 5 months postpartum. And that's important. A lot of times peripartum cardiomyopathy actually occurs after delivery, up to a few months. Now, there are several risk factors. In OBGYN practice, these 3 risk factors are typically associated with an increased risk for a multitude of diseases. That's going to be preeclampsia, or high blood pressure with end organ damage, an older individual or an older female, maternal age greater than 30, and of course, multiple gestation, or more fetuses, and means more fluid. Now, the symptoms are going to be exactly what you think they are. The symptoms are the same as dilated cardiomyopathy. S3, orthopnea, lower extremity swelling, JVD, etc. And of course, the imaging style is going to be the exact same as well. We typically get an echo, but in this case, we're looking for a significant ejection fraction decrease, typically less than 45%. We also need to look for other causes, and of course, with peripartum cardiomyopathy, there'll be no other causes. Remember, even in the post-delivery or during pregnancy, the number one cause is always going to be ischemic cardiomyopathy. That's why we get the echo. With peripartum cardiomyopathy, we expect to see global hypokinesia, right? Because it's not going to be focal, because this is not due to ischemia. Treatment is going to be GDMT, as we just went over. And of course, if they're still pregnant, it's going to be immediate delivery of the fetus. Now, it is important to know for test day that if they are still pregnant, even at 36, 37, 40 weeks gestation, we typically avoid ACEs and ARBs due to their side effect profile. And of course, you also want to understand the prognosis. This is going to be a decently okay prognosis. Most recover within 6 months. But there is a high mortality rate of 10%, or higher than expected mortality rate. A big takeaway from this slide is going to be a significant decrease in ejection fraction, less than 20% at time of diagnosis. You have the likelihood of getting heart failure again at some point in your life. So peripartum cardiomyopathy, the big takeaway point is when it occurs, what we see on imaging, global hypokinesia, of course, and then treatment. Those 3 things are definitely something that I would know for test day. So now let's go over acute decompensated heart failure. This can occur in either HFrEF or HFpEF. We will discuss HFpEF in another video. This patient will usually have a known history, but sometimes this can be the initial presentation. What I mean by that is in the question stem, they'll tell you that this patient has a history of dilated cardiomyopathy or hypertrophic cardiomyopathy. The symptoms that are going to be present all are going to suggest fluid overload. So edema, S3, JVD, shortness of breath, crackles, accessory muscle use, tachypnea, right? S3, as well as orthopnea, again, can be seen in acute decompensated heart failure. Remember, that is associated with fluid overload. When you see those on test day, that either means acute decompensated heart failure or dilated cardiomyopathy. The accessory muscle use and tachypnea is going to be highlighted in red because usually individuals with chronic dilated cardiomyopathy, typically they are at equilibrium. So their body is at homeostasis and they've adjusted. So those individuals should not be using accessory muscles. They should not be breathing faster than expected. Where individuals who are in decompensation or an exacerbation are going to be extremely short of breath. They're going to have a low SpO2. They're going to be breathing fast. They're going to be using their accessory muscles to try and get a breath in. Okay? So this is something that I would look for in test day in someone with known dilated cardiomyopathy or hypertrophic cardiomyopathy to tell me, hey, this is probably acute decompensated heart failure. The labs are going to be not really as helpful in real clinical practice, but helpful on board day. You're going to see an elevated BNP. Typically, we see something greater than 400. The higher, the more likely it is acute decompensated heart failure. This has a great NPV, or negative predictive value. This means that this is actually more helpful when it's negative or low. It should also be known, because they love to put this on test questions, that if someone is obese, let's say a BMI greater than 28 or 30, this can lead to a BNP not being reliable. Obesity actually underestimates BNP. So this can be falsely low. You might see a level of 300. Note how that's not greater than 400, correct? But if the individual is obese, it might be underestimated due to that. So a low BNP in an obese patient does not rule out heart failure. Understand this for test day, as sometimes they'll emphasize that this individual has a sedentary lifestyle, they're obese, and they'll give you their BMI to be 35. They will then show you BNP, and their BNP may be normal, maybe 200. But everything else is pointing to this as acute decompensated heart failure. They want you to know that in obese people, BNP is not a reliable marker. Now, the treatment is going to be exactly what causes the symptoms. The symptoms are going to be due to volume overload, right? All of this is due to an increase in volume. So the treatment is going to be to treat those symptoms, to remove volume, get the fluid off. Typically, the baseline treatment is going to be oxygen supplementation and IV diuretics, typically IV Lasix. Now, there is more to just this. This can now be broken down into two things: high blood pressure or low blood pressure. So if we have a normal or elevated blood pressure that's not responding to IV diuretics, we can also add on a dilator, nitroglycerin. If our BP is too low, we do still want to diurese them, but we have to be careful here, right? Because we want them to be able to perfuse their organs. Thus, we sometimes have to add an intravenous vasoconstrictor, such as norepinephrine. It is also important to know that we do not, and I cannot emphasize that enough, give a beta blocker. We stop their home beta blocker. The reason being is because of the fact of their inotropic effects. This can lead to further decreased contractility and thus more fluid overloaded. So we stop their beta blocker. Everyone gets put on oxygen supplementation, usually nasal cannula, and IV Lasix or IV diuretics. If they have an elevated BP and they're not responding to the diuretic treatment, we will give them nitroglycerin to hopefully lower that blood pressure. If they have decreased BP when they come in, and I really want to diurese them, I may want to consider putting on some sort of vasoconstrictor or norepinephrine. There is a mnemonic utilized to remember this, LMNOP, where L stands for Lasix, M stands for morphine, O stands for nitroglycerin, O stands for oxygen, and P stands for position. This is not always super helpful, and I don't really like this mnemonic because of the fact that you can see not everyone gets nitroglycerin, and you can see we do not discuss morphine anywhere. Note that morphine used to be given as it decreases preload, typically in the ventricles, more so in the left ventricle. This is why it is sometimes given also in STEMIs or myocardial infarctions. But we really move away from this during real practice. We really only use the L, the O, and the P. So although this mnemonic is helpful to break things down, I think going into it a little bit more detail is better to understand. So understand how people with acute decompensated is going to present with accessory muscle use, tachypnea, and then fluid overload. Understand that BNP is not the most reliable marker, especially in obese individuals. And then understand how we treat this. Always stopping the beta blocker. Everyone gets O2 supplementation and IV diuretics. And then we see if they need to be put on nitroglycerin if their BP is too high, or a vasoconstrictor if their BP is too low. And that concludes this lecture on dilated cardiomyopathy.